Shall we start, Lakshmi?
Yes, ma'am. We are live now.
Yeah, you start the program.
Yes.
Okay.
Good
Good
evening,
evening.
everybody. On behalf of the IAP Chennai City branch, we are very happy to welcome you to today's session of RAPP, Research Assistance for Pediatric Postgraduates and Practitioners. This is a part of the IAP Presidential Plan 2026. We are very grateful to our president, our treasurer, our EB members, and of course, the convener of this RAPP, Sridevi ma'am, our mentor and advisor, the Bhishma Pitama of biostats, as we always say, Nedusa, and every faculty who have delivered very succinct presentations over the last few months. So today's presentation is on association and causation. See, every day pediatricians encounter relationships between variables, right? So obesity and asthma, vitamin D deficiency and infections, screen time and developmental delay. But then not every association is a cause. So distinguishing association from causation is very essential for sound clinical practice and evidence-based medicine. So without further ado, may I request our convener and the brain behind RAPP, Sridevi ma'am, to take over the proceedings, to give her introductory remarks and proceed with our session. Thank you.
Thank you, Lakshmi. Very good evening to one and all. So today we have yet another session of our research assistants for pediatric postgraduates and practitioners. So we all know this novel attempt by our IAPCCB President Sudhakarji on research. So this is meant to give research assistance for the practitioners as well as the postgraduates and offer them the basic insights into the topics, basic topics of research. So we started with how to choose a research topic. Then we had a very good talk on how to review the literature, and framework of research was dealt with clearly by Priyadarshini. Then we had the research designs presented by Dakshayani, and then the sample size calculation well explained by Hemchand. So today we have our session on association and causation. Many a times these are used interchangeably, which is not correct. So to give us a clear view of how to differentiate between association and causation and what are the measures by which we describe them, Professor Kalpana is with us. So she is going to enlighten us on the topic. Over to Professor Kalpana.
Thank you, ma'am. Thank you, IAPCCP team and Shide ma'am for this opportunity. So this today's topic would be on association and causation. So the principal aim of epidemiology is to assess the or find out the cause of diseases or events, health events that are occurring. Over the past years, several such studies have been done and they have improved human health to a great extent. For example, epidemiological studies established the causal link between smoking and lung cancer, and this led to public health interventions and policies. The association between air pollution and respiratory health outcomes led to environmental regulations and guidelines. Similarly, investigations into occupational exposure to asbestos and the occurrence of mesothelioma led to workplace safety regulations. And the link between human papillomavirus and cervical cancers has informed vaccination programs and screening guidelines. So all these have been attempts at finding out the cause of health events or occurrences over a period of time. So there is a cause and there is an effect. And there is something called as association between the cause and the effect. And epidemiology aims to delineate or to find out more about this. But what is a cause and what is an association? So cause is any event or condition or characteristic which plays an important role in the occurrence of the outcome. Like smoking is the cause of lung cancer. That is meant by causation. However, association simply means the occurrence of two variables more often than would be expected by chance. Just the presence of association between two variables does not mean causation. For example, for a study which was conducted on a beach, they found out that the sale of ice creams increased at the same time and there were drowning incidents also had increased. And this, so does the drowning incidents be attributed to the ice cream? No, it just meant that it was a summertime and more people were using the beach and there's also more sales of ice creams. So association does not equal causation at all times. What can be the factors involved in causation? There are three things that can cause a disease. Like it includes precipitating factors, predisposing factors, and enabling factors. Precipitating factors are those that give the final push that triggers the effect, like an exposure to an infectious agent. While predisposing factors increase the vulnerability or the susceptibility to the effect, like age and sex or previous illness. And there are certain enabling factors which facilitate or promote the disease, like low income, malnutrition, or poor living conditions. So, how do epidemiologists or any investigator for that matter try to find out the relationship or associationship between a cause and an event? So, it is done as a two-step process. First, we try to find out whether there is actually an association between an exposure and the disease. For this, we can do if you want to learn about group characteristics, then we do ecological studies. Or want to see individual characteristics, then we have to do case control studies or cohort studies. Then what about randomized control trials? We know that randomized control trials are the gold standard of any study design, but they are not the ideal choice for finding out the cause of natural disease. For example, the same example, that is smoking and lung cancer. If you were to do a randomized control trial on smoking and lung cancer, we'd be having one group where you ask them to smoke all their life and another group where you ask them not to smoke all their life. And we see whether lung cancer is more common in the smokers group. So as you know, it is unethical and really impossible to do such a disease. So RCTs or randomized control trials are very good for determining the cause of interventions, but not for natural causes, where we still have to rely on observational studies for information. So what we have an association, we do a study, we see a cause, we see an event, and then we have a statistically significant association. How do we know that it is actually causative? So the first step would be, is the study well performed? The first step would be to have an adequate sample size, because the sample size, it has the statistical power to detect the actual difference between the cause and the effect. And it also avoids some of the random errors and bias in the study. The second is there any bias? Bias is a flaw in the way we conduct a study. For example, we say an inhaler is working well, and we had tested the inhaler only on young adults with mild disease. Obviously, the study is flawed because we haven't taken all the severity of the asthma. We haven't included children. We haven't included adults. So the way that study, when it is done improperly, can give a false association. That has to be seen when we are designing the study. Is there any bias in selection? The second is whether there's any chance occurrence, and that is why we use statistical test. Third is there any confounding factors involved in the study? We'll be dealing about confounding later sections. Finally, if there is a good study sample and there is no bias, we are sure it is not occurring by chance, and there is no effect of confounding, then finally we might associate that this is because of the cause is actually, it is because of cause is actually producing the event. What are the types of association? Broadly, we can classify them as spurious association, indirect association, and direct association. Direct association can be one-to-one causal and multifactorial associations. What is a spurious association? So spurious association is one which appears because of improper comparison. So the observed association between the disease and the factor may not be real. For example, when they did a study on neonatal mortality, and they found that babies were dying more in the hospitals than the babies that were born at home. So they concluded that babies delivered in the homes were actually safer. But this is actually a spurious association, because babies who are born in the hospitals were actually those of high-risk babies and high-risk deliveries. So this type of comparison, which is not improper, will lead to spurious association. And one of the most common things that we see across is everybody who went to the moon has eaten chicken. So, does chicken eating make you go to the moon? So, this type of association is called as a spurious association. The second is a non-causal or indirect association. What is a non-causal association? It is a statistical association. There is an association between the interest and the disease. But this is because of another factor or a common factor known as the confounding variable that is common to both the characteristic as well as the disease. So in this example, the exposures are two. One is the maternal age more than 30 years and birth order more than 4 years. And the outcome they studied was neonatal mortality. At first shot, they saw that increased maternal age had caused increased neonatal mortality. But here, the confounding was the higher order of births. So higher order of births, the confounding factor is obviously associated with higher maternal age, and that was the cause of the increased neonatal mortality. So if you haven't considered the higher birth order as a confounding variable, then we would blindly be saying that increased maternal age associated with neonatal mortality. So actually, what is a confounding variable? It is due to mixing the effect of the exposure under study of the disease with that of a third factor. So this third factor must be associated with the exposure and independent of the exposure be a risk factor for the disease. This can lead to overestimation or underestimation of the true association and can change the direction of the observed effect. Another example is the effect of coffee drinking on pancreatic cancer. So there was a study which showed that there was increased coffee drinking was associated with an increased instance of pancreatic cancer. But here the confounder was smoking. So increased smokers had an increased incidence of coffee drinking, and smoking is an important risk factor for or independent risk factor for pancreatic cancer. So smoking is a confounding variable here. And if you not considered this, we would be blindly linking coffee drinking with pancreatic cancer. So what is the real association? That is the direct or the causal association. That is the association between two attributes, which is not true any third attributes. And we are sure that there is no spurious association. When the disease is present, the factor is also present. So this is called as direct association. It can be of two types. It can be one-to-one causal or multifactorial. One-to-one causal is the variables are causally related. If we say that a change in A is followed by a change in B. So a single specific cause leads to a single specific effect, demonstrating a clear, exclusive cause-effect pathway without multiple contributing factors. Multifactorial causation, several alternative causal factors can act independently. Like in lung cancer, more than one factor like air pollution, smoking, or heredity can produce a disease independently. So once you have a statistically significant association between an occurrence and a cause and an event, that is there's two of that an exposure and an outcome. Does this association actually mean a causal relationship between the exposure and the outcome? This requires more data than a single study. For this, we need to have a lot of criteria have to be gone through before we just label the association as causal. And this is given by Bradford Hill criteria. He was an epidemiologist. Interestingly, he was the first one to do a randomized control trial in the world. And he had also given this framework against which to test whether an association is causal or not. What are his criteria? First is the strength of association. Like stronger association, then likely the two factors are likely to be causal. Consistency. Have the same results been observed in different populations, different studies, and at different times? Specificity. One specific cause leads to one specific effect. The most important among the Bradford Hill criteria is the temporal sequence. That is, the exposure must precede the outcome. Biological gradient. Is there a dose response relationship? When you increase the exposure, does the outcome also increase? Biological plausibility. Is there a biological mechanism that explains this observed association? And does this fit into existing knowledge about the natural epidemiology or the biology of that disease? That is coherence. Finally, experiment and analogy, where similar exposures can produce Thus, you have to see whether similar exposures can produce similar effects. An experiment is when you remove the exposure, does the outcome reduce? So this need all of them need not be satisfied, but broadly, if they fit into these criteria, then this statistically significant association between two variables are likely to be causal. So what are the types of causal relationships? There are two important factors. One is sufficient factors and necessary factors. Sufficient factors is one which inevitably produces the disease. That is, the presence always results in the disease. Like rabies virus, if you are infected, you will always develop rabies if you have not been treated. Necessary factors is without the necessary factor, the disease does not occur. But by itself, the factor is not sufficient to cause disease. For example, you can get infected with Mycobacterium TB, only then you will develop tuberculosis. But not all those who are infected with TB will develop the disease because it also depends on several host factors. So, based on these two, that is sufficient and necessary factors, causal relationships are of four types. One is they can be necessary and sufficient, necessary but not sufficient, sufficient and not necessary. They are neither sufficient nor necessary. So what does this mean by necessary and sufficient is without the factor, the disease never will develop. That is, it is necessary and this factor itself will cause the disease. That is, it's also sufficient. The classical example is the rabies virus. It is both necessary and by itself is sufficient to cause the disease. It is necessary, but it is not sufficient, meaning, for example, carcinogenesis is a multi-stage process. It requires promoters and initiators, but just the action of initiator promoter will not produce cancer. So factor A and B and C are individually they are necessary. They're all three are necessary to produce the disease, but individually they're not sufficient to produce the disease. Finally, sufficient or not, but not necessary. For example, if you take leukemia, leukemia can be caused by radiation exposure, and leukemia can also be caused by benzene exposure. So this factor alone can produce the disease, but so can other factors that can act alone and produce the same outcome. The last is the neither sufficient nor necessary. This is a classic example of a chronic disorder where there are multifactorial causes. Like factor A cannot produce a disease independently. It can produce a disease along with factor B. So also factor C along with factor D or factor E along with factor F. So a combination of factors should act to produce that disease that is called as neither sufficient nor necessary. The classical example would be a coronary artery disease where you have age and sex, genetic predisposition, lifestyle modification, metabolic and environmental factors. All of them are necessary to produce a disease, but not single one of them cannot produce the disease independently. What are the measures of association? So measures of association will be broadly classified as absolute measures or relative measures. An absolute measure simply means a difference in the outcome frequency between the exposed and the non-exposed, while a relative measure is the ratio. The classical example is risk difference for absolute measure and relative risk or odds ratio for relative measures. In practice, as you all know, relative measures are used more frequently than absolute measures. What do we mean by relative measures? So relative measures, they measure how strongly the exposure and outcome are related. So they are very important to test the hypothesis. They show how more or less likely a subject is to develop disease if he is exposed. So it can identify the determinants or the cause of disease can be identified by relative measures. But absolute measures is where evidence has already shown that it is very important. That is the cause. It is very important to produce that event. But why we use absolute measure is they reveal like how much disease risk changes when the exposure is added or removed. So they are very important at population level impact of an intervention. One simple example to demonstrate relative and absolute measure is when we are talking about the risk of developing myocardial infarction in smokers. So the relative risk, which is a relative measure, just measures the risk in smokers by risk in non-smokers. Suppose it is 5 cases per 1,000 person years divided by the non-smokers incidence is 1 case per 1,000 person years. So the relative risk is 5. And the absolute difference, that is 5 cases minus 1 case, will give 4 cases, which is the absolute risk difference between smokers and non-smokers. So what does this say? So relative measure says that there is a relationship between smoking and myocardial infarction, and it is 5 times higher. So it supports the hypothesis that smoking is a risk factor for myocardial infarction. But absolute measure says that the difference in incidence is 4 cases. It tells you how much myocardial infarction can be reduced if you were to reduce the number of smokers. So in public health planning, absolute measures are used more often. Then the important concept comes as risk and odds. What do we mean by risk and what do we mean by odds? In general terms, risk means a negative perspective, but in epidemiology, risk means the occurrence of an event or an occurrence of an event where it did not exist. In other words, risk means incidence of a disease. So this is usually measured in incidence in cohort studies or cohort studies where we can measure the risk. But most often in experimental settings, we cannot measure the incidence. Like you cannot measure how many cases of cancer by following up some people. So in that case, we use the odds where we measure the existing exposure and existing outcome and see whether they are related. So odds is a substitute for risk. Some designs capture exposures and outcome rather than new ones, like cross-sectional studies and case control studies, where the odds ratio is used more common. So risk means the chances of something happening dividing the chances of all things happening. Well, odds means the chances of something happening and the chances of it not happening. To explain this more, suppose you're in a class of 40 and an instructor chooses you to answer your question. What is the risk or probability that you will be chances will be 1 in 40. That will be your relative risk. That is 1 divided by 40, which is 0.025. But what are your odds is odds of you being chosen against 39 others who will not be chosen to answer the question. So odds becomes that 1 divided by 39. The denominator, although they're almost identical, risk uses the total number, while odds compares the chance of you to the event not occurring. So that is where you use odds ratio. So relative risk is the incidence of among exposed and divided by the incidence among unexposed. So it is a direct measure of the strength of the association. So we are all familiar with this 2 by 2 table where we have the disease and not found there is no disease and the exposure is there and the exposure is D. So the total exposed will be A plus B and the total unexposed will be C plus D. So risk is incidence among exposed, which is A divided by A plus B, divided by the incidence among unexposed, which is C divided by C plus D. So the relative risk just equal to 1 means there is no association. If it's more than 1, it indicates a positive association, possibly causal, and negative 1 is a negative association, possibly protective, but that depends on what study that we are taking up. Then what does the odds ratio? Odds ratio is a preferred measure when you're not able to identify the risk. So it is the probability of the event occurring. It can be used in both cross-sectional as well as case control studies. In case control studies, the odds is calculated as exposure in the cases divided by the exposure in the controls. While in cross-sectional study, it is calculated as odds of disease in the exposed group divided by the odds of disease in the non-exposed group. For example, if probability of an event occurring is taken as P, probability that the event does not occur is 1 minus P. That is, if it occurs one time, 1 minus P is the probability the event does not occur. So the odds will be P divided by 1 minus P. For example, if the probability of event occurring is 0.7, then the odds of the event is 0.7 divided by 1 minus 0.3, or 1 minus 0.7, which is 0.3. So the odds of the event occurring is 2.33. Applying it to the same 2 by 2 table. So here we have the odds of the disease among exposed. So it will be the A is A by P divided by 1 minus P. So P is A divided by A plus B. That is the divided by 1 minus A by A plus B. Similarly, the denominator will be C divided by C plus D. That is the and that is divided by 1 minus C by C plus D. So when you just reduce it algebraically, it becomes AD by BC, which is a cross product of this 2 by 2 table. So the odds is again interpreted in the same way. That is a positive association is results greater than 1 indicates a positive association. Exactly equal to 1 might mean there is no association, or less than 1 might mean there is a negative association. So it is interpreted in different study designs. In case control study, the interpretation is based on the odds of exposure in the cases compared to the odds of the exposure. And in cross-sectional studies, odds of disease in the exposed compared to the non-exposed. Coming to the next section, which will be the absolute risk difference with the attributable risk. So what proportion of that risk is disease is attributed to a specific exposure? For this, we need to know the incidence in the total population, and this is divided by the incidence in the unexposed or the background risk. So population attributable risk will be A minus B by N. So in summary, the problems in causation would be that the existence of a association does not necessarily mean a causation. The concept of a single cause and a concept of multiple causation have to be kept in mind. Confounders have to be found out in every study. Systematic error or bias can produce spurious association. And remember that no statistical method can differentiate between causal and non-causal associations. And because of these many certainties, we prefer terms like causal inference or causal possibility or likelihood rather than causal conclusion. And all of them are important in formulating policies. Like all these assumptions are helpful in formulating policies rather than waiting for unequivocal proof, which might be unattainable in several disease conditions. So this is my, here we conclude the talk on associations and causations. Thank you.
Thank you, Kalpana. Very well explained. If we are to interpret any observational study, we need to know the difference between association and causation and the parameters associated with it. Very well explained. Now over to our mentor, Nadajarian sir, for his remarks.
Hello, good evening to everyone. Dr. Kalpana has done a wonderful job. It is very everything actually we need to have at least 2 or 3 hours causation as a separate
Kalpana, you
lecture
can stop
and
sharing. You can stop sharing. Sorry,
Yeah,
sir.
that's no problem. And maybe this one association also can be considered for 2 or 3 hours lectures. It made it very concise actually and brought out all the things including maybe she has actually defined what is causation and what is association, and she has covered the extensively types of association including many good examples, very relevant examples and simple to understand. And she has went into the extent of maybe measures of association extensively, right? Starting from attributable risk to odds ratio and explaining, giving examples and all, and how to calculate. Maybe you cannot actually be expert in actually calculating as well as understanding what is this concept of odds ratio and relative risk. Of course, she has given a nice exposure to the thing and kindled you to learn what is this relative risk and odds ratio, which is very commonly used in maybe publications as well as presentation and other thing. You should be familiar with those things. Then two other terms are there which can be sometimes confused with this causal association as well as causal association and the simple association. Terms are correlations or relationship as well as agreement. Correlation is nothing but how far the one measurement correlates with the others. Like as the weight increases, as the height increases, whether the weight increases, that is positive correlation we will be having. It can be a negative correlation where the exercise increases, heart rate subsequently comes down on the thing. Then there can be curvilinear this one relationship, as well as there may not be any real correlation with two variables which are considered to be having correlation. The other thing what I have mentioned is agreement. How far but particular measurement or two instruments they correlate in the readings, they actually agree with them. Take the example of weighing scale. Okay, one measures as 10 kgs, others also measuring 10 kgs, or maybe little variant within acceptable 95% confidence interval. It can be represented maybe very well in constructing bland almonds graph. And for correlation, maybe we need to go in for correlation coefficient calculation and other things. So this was very useful lecture. I appreciate Kalpana's effort in bringing out so many details within this concise. Maybe I have stolen 5 minutes and she has actually finished it in 25 minutes. Thank you very much. Thank you very much for the opportunity, and nice that you have made out very nicely, especially measures of association. You did it very elaborately. I appreciate that. Thank you.
Thank
Thank you for the
Thank you,
opportunity.
sir, for
All
adding
the
your
best.
note on correlation and agreement too. And next month, I think because of the Golden Jubilee Pedicon, we won't have a session on RAP. And in the month of September, we will meet with basics of biostatistics. Over to Lakshmi.
Thank you so much, ma'am. Thanks to our mentor and legendary teacher, Nedu sir. Thanks to Sridevi ma'am for, who has been convening these sessions from the start. And of course, the expert faculty. We have had very wonderful sessions so far. All our sessions have been live streamed on YouTube. We have been periodically sharing the links. I shall do the same tonight also. So on behalf of IAP CCB, very grateful to the entire team for putting together such a session. For me personally, there were several memorable takeaway slides, and what was the best of all was how Madam absolutely simplified RR and the odds. So, she very beautifully explained how relative risk compares probabilities and odds ratio compares odds. So, how I like to remember is RR, relative risk, real world risk, odds ratio, OR, odds on the scoreboard. So, this is how I've always remembered. But Kalpana ma'am today made it, so easy. So I don't have to remember this mnemonic. She just made me understand the science behind it, the stats behind it. So thank you, ma'am. It was a wonderful session. I would like to acknowledge the presence of our OB treasurer, Dr. Anandi, and our EB members who have joined with us today. Thanks to the August audience. Thank you very much. And as Sridevi ma'am said, we will meet again in September. Till then, let's all gear up for our Golden Jubilee Pedicon and make it a very grand success. Thank you very much and good night.
Good night.
Thank
Thank you.
Thank you, Lakshmi. Thank you, one and all.
Thank you, ma'am.